get discussed by our guest today, speaker, Dr. Kiran Rajagopal. Is a coordinator and consultant intensivist in the Department of Critical Care Medicine, Sri Gokulam Medical College, Trivandrum. And welcome to you, sir.
Thank you, Bharath sir. Thank you for the intro. And good afternoon, everybody. So today we will be discussing about an important topic or important case in critical care, that is the ARDS or Acute Respiratory Distress Syndrome. It is actually a very vast topic. And for the nursing perspective, as nurses, you need to know some of the basic aspects of ARDS, because you will be often seeing this ARDS cases very frequently. You will be seeing ARDS cases very frequently. And in order to give a proper care for such patients, you should know what is actually happening with the patient. So that is the main purpose of today's session. But sir, feel free to interfere at any point of time.
Sure, sir. Thank you.
Okay. So basically, we will start with the case. So this is a 36-year-old gentleman, non-diabetic for the last 3-4 years. And he was basically admitted in the ward initially with a history of fever, complaints of fever and rhinitis for 3 days duration. And 3 days back, he had, since 3 days, he was having fever, rhinitis, and he was admitted in the ward. And today is the 4th day. Okay, so in the first 1 to 3 days, the vitals were stable, saturation was normal. Okay, and the respiratory film array which they sent came out to be influenza positive, and he was started on oseltamivir, antiviral, and other supportive medications. And on the 4th day, he started to develop a mild breathing difficulty, mild tachypnea, respiratory distress. And towards evening, the distress progressed. In between, the primary consultant had taken a CT chest and X-ray, had taken an X-ray first, and seeing the X-ray, they took a CT chest. Towards evening, the distress progressed, and RRT was called. And you are a nurse working in the critical care unit, and you had that RRT duty for this day. And when you went to attend the RRT call, you saw that the saturation was around 86% on 10 liter O2, and his respiratory rate was around 40 per minute. Okay. So this was his CT chest, which was taken early in the morning, and this was the X-ray. Okay. So when you arrived at the scene, you saw that the patient was desaturating on 10 liter O2, tachypnic, and you just had a glimpse of the X-ray and CT, and this looked like this. So what do you think the patient is having? Anybody can answer? If anybody is willing to answer.
So someone from the audience, please have some interaction. Can anyone comment what you can appreciate on this CT scan?
Okay.
Sir, they message on chat box. They don't allow to speak.
Okay, fine.
Okay.
Okay, fine.
Chat
Okay,
screen,
so
I couldn't see anything. Okay. Yeah, please carry on.
Okay. So this is the situation you're facing now. So what will you do next, or what are you anticipating next? You have a doctor nearby, and what are you anticipating that what the doctor is going to do next? Okay. Or what you will arrange. Definitely patient needs to be shifted to the ICU. Okay. And what all will you arrange? Because patient is desaturating, he's already on 10 liter oxygen and still he's desaturating and tachypnic. So you need to do something before shifting, right? So you will either keep an NIV, non-invasive ventilation, start on a non-invasive ventilation, or an HFNC. HFNC may not be available in ward, but still for the sake of the class, I am mentioning HFNC. So most probably you will be initiating the patient on an NIV and shifting to ICU. So the patient is basically have.
Excuse me,
Okay.
sir, we had a response from the chat box.
Okay.
One of the attendee had responded, he needs NIV support.
Yeah, excellent, correct. You're spot on. The patient needs a NIV support.
Yes.
Definitely. So you initiated on an NIV and shifted to the ICU. So what is happening with the patient? He had a viral pneumonia 3 days. He was admitted with a viral pneumonia 3 days back. Now his X-ray and CT worsened. He's having bilateral infiltrates. He's desaturating. What is he having? Is he having a hospital-acquired infection, or is it some secondary pneumonia or something else, any cardiac failure or something? Okay, or something else. What is he having? Anybody? Okay, some response like pneumonia. He already has a pneumonia. Okay, he already has viral pneumonia, influenza, which was positive. So, what is the complication which you are facing now? If anybody has an idea, you can put it on the chat box. Okay. So basically, he is having an acute respiratory distress syndrome. That is secondary to the viral pneumonia. Okay. Now, how do you classify or how do you define this? So this was a Berlin definition, which was postulated in 2012. Okay, the definition for ARDS is known as Berlin definition. And by that definition, we define ARDS as it is a syndrome. Actually, it is not a disease per se. It is a complication of some other primary disease. Okay. So it is a syndrome characterized by that is onset within 1 week of clinical insult. Okay. Here the patient had viral pneumonia 3 days back, and on the 4th day, he developed this complication. So it fits properly. Onset within 1 week of clinical insult. And bilateral radiographic opacities. Our patient's X-ray, CT all had bilateral opacities, and it should not be explained by pleural effusion, atelectasis, or nodules. That is, patient should have bilateral opacities in his X-ray or CT, but that should not be due to any pleural effusion or atelectasis or any other nodules. Okay. And third criteria is respiratory failure should be there, and it should not be, the cause of respiratory failure should not be any cardiac failure or due to fluid overload. And there should be evidence of poor systemic oxygenation, which is depicted by PF ratio. We will discuss PF ratio in the coming slides. Okay, so evidence of poor systemic oxygenation, PF ratio that is less than or equal to 300. But you see, they have an additional if condition also, that is PF ratio less than or equal to 300 with a CPAP or a PEEP of more than or equal to 5. Okay, so this is the ARDS Berlin definition of ARDS, that is onset within 1 week of clinical insult, bilateral opacities, which should not be explained, by pleural effusion, atelectasis, or nodules, and there should be respiratory failure, and which is not contributed by cardiac failure or fluid overload, and PF ratio less than or equal to 300 at a PEEP or CPAP of more than or equal to 5. So, going by this definition, can we classify this patient as ARDS? Yes or no? You can put it in the chat box. That is, going by this definition, can we classify this patient as a? We know clinically, we know this patient is having ARDS, but going by this particular definition, my question is, going by this particular definition, can we classify it as a ARDS? I will give some additional information that echo was normal. There was no evidence of any fluid overload, and there was no effusion or atelectasis or nodules. Okay, so just think and answer. Okay, I was mentioning about PF ratio. What is PF ratio? That is nothing but P partial pressure of oxygen divided by fraction of inspired oxygen, PaO2 by FiO2. PaO2 we get in ABG. Okay, you are all familiar with ABG. I think session was on ABG was conducted few months back. So in ABG we get the P partial pressure of oxygen, PaO2, and FiO2 we know we are setting the FiO2. Okay, the ratio of PaO2 by FiO2 is known as PF ratio. Normal PF ratio, that is your PF ratio, my PF ratio, all will be more than 400. That is, our PaO2, if you take your own ABG, your ABG will show a partial pressure of oxygen around 98 or 100 something. And you are breathing atmospheric air, where the FiO2 is 0.21. That means 21% of the atmospheric air is oxygen. That means the fraction of inspired oxygen is 0.21. So 100 by 0.21, that roughly comes around 500. Okay, so PF ratio more than 400 is normal. Okay. Now let me ask one question. You have to answer this question. You have two patients, A and B, and you took ABG for both patients. The PaO2 for patient A is 60 and PaO2 of patient B is 80. Now tell me who has better oxygenation. Can somebody message the answer? Okay, somebody has responded B. Okay, fine. So there is a response which who says that PaO2 is, patient B is having better oxygenation. Okay, fine. Now I will provide some more details. The patient A was on FiO2 0.3, that means 30% oxygen when the ABG was taken. And patient B was on FiO2 100, FiO2 1, that means 100% oxygen when the particular ABG was taken. Now, is there any change of opinion? Or are you still sticking on with your answer? Or is there any change? Again, my question is, who has better oxygenation? A. So another response has come, that is A. See, just looking at the PaO2 alone, you felt that patient B had better oxygenation. But understand the point that when you assess a patient for oxygenation, or when you assess an ABG, don't simply look at the PaO2 value alone. Always look at the PaO2 with the reference to the FiO2. If you eliminate, or if you haven't looked at the FiO2, you felt that patient B had better oxygenation because PaO2 was 80 and for patient A it was 60. But when FiO2 came into picture, you see patient A was at 30% oxygen and having a PaO2 60, while patient B was on 100% oxygen and having a PaO2 of 80. So the PF ratio is 60 by 0.3, that is 200. And here the PF ratio is 80 by 1, that is 80. So patient A has a better PF ratio than patient B. So definitely patient A is having better oxygenation. Okay, hope you got the point. Never look at the PaO2 alone. Always look at PaO2 and FiO2 combined and see the PF ratio. So this is the significance of PF ratio. Hope you got the point. Now, based on the PF ratio, we can classify ARDS into mild, moderate, and severe. So anything less than 300, PF ratio less than 300, at a PEEP of more than or equal to 5. That is very important. At a PEEP of more than or equal to 5. Okay. So anything less than 300, we call it ARDS. Okay. And anything from 201 to 300, that is mild ARDS. 101 to 200. If the pH ratio is from somewhere between 101 to 200, it is moderate ARDS. And if it is less than 100, we call it severe ARDS. Got the point? So our patient A has moderate ARDS, while patient B is having severe ARDS. Okay. So mild ARDS, the PF ratio less than or equal to 300, moderate ARDS less than or equal to 200, severe ARDS less than or equal to 100. Okay. So again, my question, and remember the question I asked earlier. Going by the Berlin definition, can you classify our particular patient as ARDS? I haven't gotten a response for that. By going by Berlin definition, can you classify our patient as ARDS? Okay. So what is the significance of the severity classification? You can see that mild ARDS, the mortality increases as the severity of ARDS increase. Okay. So if somebody, the patient you are caring for is having severe ARDS, you should understand that the mortality rate is very high. Still no response, I think. Okay. See, the problem with Berlin definition. See the fourth criteria. PF ratio less than or equal to 300 at a PEEP of more than or equal to 5. Our patient was on 10 liter O2.
Excuse me, sir.
Yes.
Can you make your voice a little bit louder?
Oh, sure. Sorry. See, our patient, the fourth criteria of ARDS mentions that PF ratio should be less than 300 at a PEEP of more than or equal to 5. Okay. And our patient was on 10 liter O2. So, can you tell me how much PEEP? Can you tell whether the patient on 10 liter O2 is getting any PEEP or so? No. So, for us to understand the PEEP, the patient should be at least intubated or maybe on NIV. Okay, so this criteria may not be applicable when the patient is on HFNC or on a oxygen mask. Okay, that is why I told you we cannot classify the patient or particular patient just by the Berlin criteria, although clinically he is having ARDS. Hope you got the point. So they came up with a new global definition of ARDS, a slight modification they made. As per the Berlin definition, we need to get the PEEP. For that, patient should be intubated. But since the COVID pandemic and all, the use of HFNC is now increasing. And instead of NIV, some use HFNC for respiratory failure initially. So again, using HFNC, how will we know the patient know the PEEP value? So a patient on HFNC we cannot label as ARDS just by going by the Berlin definition. That is why they modified the definition. That is, they added a HFNC flow rate of more than or equal to 30 liter per minute. If the patient is on an HFNC requiring a flow rate of more than or equal to 30 liter per minute, or on an NIV with a CPAP of more than 5, then we can classify it as a ARDS. Okay. And some centers, some resource limited centers may not have an ABG machine. So how will we know the PaO2 to calculate the PF ratio? So instead of that, they added one more point. You can go by the SpO2 by FiO2 ratio. You know the FiO2, you know the SpO2. So you can divide the SpO2 by FiO2, and if it is less than 3.15, then we can calculate it as we can assume that it is a case of ARDS. Okay. And what are the causes of ARDS? It can be direct causes. Direct causes means direct lung injury, or it can be indirect causes. That is, the primary insult may be somewhere else, but the inflammatory mediators and all are causing damage in the lungs. So direct lung injury, the most common causes are pneumonia, aspiration, pulmonary contusion, or fat embolism post long bone fractures, or drowning, or toxic inhalation of gases, or burns, etc. These causes direct lung injury. And indirect lung injury, the examples are sepsis. There will be inflammatory mediators in the bloodstream, and that will be causing the injury to the lung, or severe trauma, patient on cardiopulmonary bypass, pancreatitis, transfusion mediated lung injury, TRALI, or any non-cardiogenic cause. Okay, these are the causes of ARDS, direct and indirect causes. Okay. So what is happening to the patient's lungs when he is having an ARDS? There is diffuse alveolar damage will be there. His alveoli will be diffusely damaged, meaning there will be gross damage of the alveolar units in the lung. Okay, that is a hallmark of ARDS. So basically, it is an inflammatory process. There are a lot of inflammatory mediators being released, and they are causing damage to the alveolar capillary membrane. So what happens when alveolar capillary membrane is damaged? There will be alveolar flooding, there will be interstitial edema, there will be necrosis of the alveoli. Okay, and finally, at a later stage, it can lead to fibrosis. See, this is the normal alveoli, which normally should contain the air, so that the inspired air, so that the oxygen will be oxygen and carbon dioxide exchange will happen, and the lung will look like this on an X-ray. In an ARDS lung, you can see that the alveoli, instead of getting filled by the air, it is fluid filled because of the loss of alveolar capillary barrier. So it will be fluid filled, as a result of which the oxygen carbon dioxide exchange won't happen properly, and the X-ray will look like bilateral opacities. Okay. So this is again another picture. You can see that this is the normal alveoli. There is air and other surfactant and all, and alveolar capillary barrier, it is intact. While in an ARDS lung, the alveolar capillary membrane integrity is lost. So what happens? There is exudation of, say, inflammatory mediators and fluid, causing interstitial edema and alveolar flooding. Okay. Now coming to the clinical features, the typical clinical feature is hypoxemia. Even though you keep him on oxygen, his oxygen levels won't increase significantly. Hypoxemia is the hallmark of ARDS, and there will be rapid deterioration, as we saw in our patient. He was okay for the last 3 days, except for a fever and rhinitis, but on the 4th day, suddenly he desaturated and developed respiratory distress. Okay, so hypoxemia and rapid deterioration, plus other signs will be the tachypnea, etc. will be there. Okay, coming back to our patient. So the patient was put on NIV and shifted to the ICU. So after 1 hour of NIV, you are monitoring the patient for 1 hour of NIV. Okay, your consultant told you, like, keeping him on NIV and just monitor for 1 hour. Repeat an ABG after 1 hour, and we'll see. And what will you monitor? While the patient is on NIV, what will you monitor? Can you keep the patient, such a patient, on NIV for long? Maybe a day or 1 or 2 days. Okay. When you kept him on the NIV, maybe saturation might improve slightly to somewhere around 90. Okay. Tachypnea came down a bit, still tachypnic, but came down a bit. So can you keep him for long? No. Okay. Since you have kept him on NIV and you have taken an ABG, and now you have, when you see the PF ratio, it is somewhere around 120. What will you do? That is still low, right? So what will you do? What will you anticipate? What should you anticipate in such a situation? When such a patient comes to your ICU and you are looking after him, what should you anticipate? What is going to happen to him, or what is going to be done to him? Okay. We will go with intubation and mechanical ventilation. Basically, mechanical ventilation is the mainstay of treatment for ARDS. This NIV, HFNC and all can be tried in a case of mild ARDS, that is when the PF ratio is somewhere between 200 to 300. Yes, standby intubation, right? Okay, so only in a case of mild ARDS, that is some PF ratio is between 200 to 300, you can give a short trial of NIV. You cannot keep NIV or HFNC. You cannot keep NIV or HFNC for long. You have to observe him for a maximum of 1 or 2 hours. If he is not improving at least after 2 hours, then you will have to proceed with intubation. Because if you are pushing on the NIV and you are delaying intubation, you are going to reduce the patient's chances of survival. Okay, delayed intubation, mortality will be more. Okay, so when you keep the patient on NIV, you have to closely monitor him for any worsening. Yes. So if you the main approach to ARDS patient, the mainstay is mechanical ventilation, ventilatory management. Then you have to treat the precipitating cause. What has caused the ARDS? I told you ARDS is not a primary disease per se. There should be something which has caused the ARDS. The precipitating cause. It can be a pneumonia. It can be drowning, related to drowning, or it can be due to pancreatitis, or it can be due to sepsis, or it can be due to pulmonary fat embolism. Okay, so basically address the precipitating cause. If it is infection, you can address with the antibiotics, or if it is viral pneumonia, you can maintain him on antivirals, etc. The mainstay is ventilatory management, then ICU supportive care. If infection is present, treat that. And some adjuvants to ventilator management are there. We will see that. And finally, rehabilitation and recovery. These are the main headings of treatment for a ARDS patient. And now we have put him on a ventilator. Okay, he has been intubated and he has been mechanically ventilated now. Okay, now what is our aim? Okay, what are you monitoring? What parameters are you monitoring, or what are you, what complications are you trying to avoid? Okay, so our primary aim in ventilating an ARDS patient is basically we want an adequate level of oxygenation. Okay, that is why we intubated him. We want an adequate oxygenation, but we have to minimize the risk of VILI. That means ventilator-induced lung injury. Okay, suppose you have a balloon and you are inflating the balloon. You are continuing. You are going on inflating the balloon. What will happen after a point of time? It will burst, right? So that is the same situation with our alveoli. Our alveoli units are like balloon. If you are, and in ARDS, there is another concept known as the ARDS lung. That is the lungs of an ARDS patient. We call it as a baby lung. That means, the size of a baby lung, the lungs of a baby will be small, right? But the size of an adult lung will be more. But an ARDS patient functioning lung will be as small as the lungs of a baby, because the remaining part of the lungs will be, as you have seen, the alveoli will be flooded and it will be non-functional or collapsed, atrectic, and it will be non-functional. So the functioning unit of an ARDS patient, the size of the lungs will be as small as the lungs of a baby. That is why ARDS lungs are known as baby lungs. Okay. So if you are inflating a large amount of tidal volume, 600, 700, 800, if you're inflating a large amount of tidal volume, what
Sir,
will happen?
I couldn't hear your voice.
Okay. Okay. Am I audible now? Am I audible?
Sir, you have some network issue, I think.
Okay, let me see.
Your voice is breaking sometimes. Okay.
Can you see the screen?
Your screen is visible, but your voice is sometimes breaking.
Is it okay now? Okay. Is it okay?
Yes, sir.
Sir, we just request you if you can just close your camera, because there seems to be a little bandwidth issue. So you can save your bandwidth by offing your camera, then it will be more clear. Sir.
Okay, fine. Okay. Hope the issue is sorted now. Okay. Am I audible?
Yes, sir. Yes, sir. Audible.
Okay, fine. So our main aim is to minimize the ventilation injury. So, and if you are inflating the lung with a large amount of tidal volume, what will happen? The ARDS, the affected lung alveoli will be already damaged. It will be closed. Okay, so the large volume of air will go to the alveoli which is normally functioning, and you'll be overinflating the alveoli like the balloon, and it will get damaged. So already 60 to 70% of the alveoli are damaged, and because of your overinflation and inappropriate ventilation, you are damaging the functioning alveoli also. Okay, so we have to minimize such ventilation-induced lung injury. So when we are ventilating a patient, what are our targets? So we keep a tidal volume target of around 6 ml per kg of ideal body weight. Remember, ideal body weight. Okay, suppose the ideal body weight of a patient is around 60. We keep a tidal volume target of around 360. Got it? Okay. So we don't want to keep a tidal volume beyond 6 ml per kg. We don't want to keep a tidal volume of more than 6 ml per kg. Okay. So that will cause this volume mediated injury to the lungs. So our target is 6 ml per kg of ideal body weight. So you have to monitor the ventilator screen for the expiratory tidal volume. Initially, when you have put him on ventilation, his lung compliance will be bad and his volume will be lower. But as the lung recovers, his volume will increase. So if he is on pressure control ventilation, you will have to come down on the pressures. Okay. So you will have to monitor whether the patient is getting exceeded tidal volume. Okay. And we usually keep a PEEP of around 5 or plus, more than or equal to 5. And there is another entity known as plateau pressure. Plateau pressure means pressure in the alveoli. We cannot directly see it on the ventilator screen. Instead, we have another parameter known as peak inspiratory pressure. Okay. So peak inspiratory pressure is not equal to plateau pressure, but our goal is keeping plateau pressure less than 30. Plateau pressure may not be visible directly in the screen, but keep an eye on the peak inspiratory PIP, peak inspiratory pressure. At least alert your doctor if it is going above 30. Okay. And regarding the oxygenation goal, we need a PaO2 of around 55 to 80 or 60 to 80. We don't need a saturation of around 100%. We never need a saturation of 100%. Reduce the FiO2 as soon as possible to maintain a saturation of around maybe 80 to 95 or around 90 to 95%. Okay, we don't need anything beyond 95 or 96. Don't need 98, don't need 99, we don't need 100. Okay. So because in order to excess of oxygen is also excess of oxygen can also produce harm. Okay. And pH we can keep around 7.3 to 7.45. Okay, these are the ventilation targets. Okay, basically you will have to look at the peak pressures. We will have to look at the tidal volume, whether he is receiving more than 6 ml per kg ideal body weight. You will have to calculate the ideal body weight based on the height, and you have to calculate the required tidal volume and see whether he is receiving more than 6 ml per kg. Okay, so these are the lung protective ventilation targets. So this was devised by ARDS net, and this is the ARDS net protocol for lung protective ventilation strategies. And regarding whether volume control mode is better than pressure control mode or vice versa, there is no such superiority of one or the other. You can either put him on a volume control mode or you can put him on a pressure control ventilation, depending on your choice or convenience. There is no advantage of one over the other. Okay. So basically, the low tidal volume is the cornerstone of management, ARDS management. That is, when there were a lot of studies comparing tidal volume of around 6 ml per kg ideal body weight versus 12 ml per kg. And what they found was that when in patients who were ventilated with the 6 ml per kg, the mortality was less by 9%. There was a significant reduction in mortality when patients were ventilated with the 6 ml per kg body weight. So never ever allow the patient's tidal volume to go above the required amount. Okay. Usually we see sometimes patient receiving 600, 700 as the lung condition, patient will be on pressure control ventilation. And as the lung compliance increases, his volume gradually increase from 400 to 500 to 600, 700. If undetected, it will even go up to 1000 liters. So you are causing a great harm to the patient. So you have to closely monitor the tidal volume, whether it is improving or increasing or decreasing. Okay, and you have to intervene according to that. Okay, always keep the tidal volume 6 ml per kg, expected tidal volume 6 ml per kg in mind. Okay. So this is a ventilator screen, and this is what I told. See this peak pressure or peak inspiratory pressure. Always keep an eye on this one. Even though this is not same as plateau pressure, just keep an eye on peak pressure, and if it is going beyond 30, you have to alert your clinician, and you have to keep an eye on the expiratory tidal volume, whether it is going beyond the required amount. Okay. And some other techniques or other modalities, we can, once he is intubated, we can sedate him. And regarding this neuromuscular blockers, muscle relaxants, there is no, actually the studies have found that there is no pointing in continuing endlessly giving muscle relaxants for weeks and all. There is no benefit there. There is no mortality benefit for that. But in the initial 48 hours, you can definitely use a muscle relaxant, because in the initial 48 hours, what we are doing is we are giving rest to the lung. Basically, we are giving time to heal. So at that point of time, if there is patient ventilator asynchrony, if he is fighting with the ventilator, then again the healing process will be hampered. So in the initial 48 hours, you are justified in using a neuromuscular blockers, and beyond that, on SOS basis only. There is no need for a routine neuromuscular blockade. Okay, so you have initiated on the lung protective ventilation. You have initiated on sedation, neuromuscular blockers, and after 24 hours of these interventions, the ABG, next day morning ABG came as the PF ratio is still 120. Okay, PF ratio is still 120. So what will you do next? Any idea? Anybody has any idea regarding what you are going to do next? Patient was ventilated 24 hours back. 24 hours, you gave lung protective ventilation. All the parameters were monitored. It was appropriate. Sedation was given. Neuromuscular blockade was given. And after 24 hours, next day morning, again, the ABG showed a PF ratio of 120. So what, any idea what you are going to, or what you are going to do next? What all you should anticipate next? Anybody has any idea? Any response? No response. Okay. We will go with prone ventilation. Hope you all have experience with, you all have cared for a patient on prone ventilation. I assume. Okay. So after lung protective ventilation, we will have to give some amount of time, maybe 24 hours at least, before proning, before the lung gets optimized, before the ventilatory parameters get optimized. We will have to give at least 24 hours for that. And even after 24 hours, if the PF ratio is not improving, if the PF ratio is not improving, you will have to go for prone ventilation. You have to understand one fact. This prone ventilation is not a salvage therapy. It is not something which you try desperately at the end of all options. Okay, I have exhausted all my options. There is nothing left. Okay, then maybe we will prone the patient. It's not like that. It is a treatment option. It is not a salvage option. Okay, so you optimize, you may maintain him on a lung protective ventilation, give some time around 24 hours for optimizing. And if there is no improvement, if still the PF ratio is less than 150 after lung protective ventilation for sufficient amount of time, go for prone ventilation. Basically, PF ratio, if it is less than 150, okay, go for prone ventilation. The advantage is that you can see here. See, when we lie supine, the weight of the heart and mediastinum and all will compress the lungs and will cause some amount of atelectasis. There are many theories for the benefit of prone positioning. Some of them are beyond what you need. So just understand this point. So when you are lying supine, the weight of the mediastinum and the heart compresses due to the effect of gravity, compresses the basal portions of the lungs and cause atelectasis. So what happens? What will change when you make him prone? You can see the weight will be, the compression of the heart and mediastinum of the lungs will be reduced. Got it? So there will be more alveoli will open, lung compliance will improve, oxygenation will improve, and VQ mismatch will improve. See, when you are lying supine, the heart will be compressing these much portions of the lung, while lungs are already damaged by ARDS. So again, some normal alveoli, these are compressed because of the weight of the heart and mediastinum. But in prone position, only this much portion of the lungs are affected. Okay. So advantages I have mentioned: improved gas exchange, more uniform alveolar ventilation, improved lung compliance. Okay. And there is a cardioprotective effect also. It will reduce the afterload to the RV, And so it is basically RV, right side protective. Proning is a right side protective technique. Okay. So overall, it is beneficial. And can you prone all the patients? Is there any absolute contraindication for proning? Actually, the absolute contraindication, that is, in this patient, you should not prone. Situations are very few. That is, one is the patient with a significantly increased intracranial pressure, a traumatic brain injury or a stroke with a significantly raised ICP, or patients with unstable vertebral cervical fractures. These are the only few absolute contraindications. Others are all relative. We can do proning under like hemodynamic instability is not a contraindication for proning, but maybe severe hemodynamic instability on triple supports or more. Maybe in such cases you can withhold proning. And while you are attending a proning patient, or while you are proning a patient, always make sure that his eyes are free of compression, because if you compress his eyes, it can lead to blindness in the brightness. And then you have to pad the pressure points, especially the axilla, breast in female, then genital area in males, etc. You have to pad pressure because it can lead to pressure injury and even gangrene. Okay. So other complications you anticipate are there will be endotracheal tube occlusion or accidental extubation, pressure source, etc., or pneumothorax or cardiac arrest, etc., or kinking of any vascular catheters, such. And raised intra-abdominal pressures because of your bolsters and all. If the abdomen is not freely moving, your abdominal pressure will increase, and that will hamper with your ventilation. So you have to monitor for all these. You have to monitor the ventilator screen. You have to see whether there is an sudden increase in the peak inspiratory pressure. So it can be due to a ET tube blockade, or it can be due to any pneumothorax, etc. So you have to always carefully monitor the patient and the ventilator. Okay. So regarding the timing, that when will you prone? I told you, you initiate him on a lung protective ventilation and give time for optimization of at least 24 hours. And after 24 hours, if still PF ratio can definitely go for proning. And we usually give proning for a continuous session of around 16 hours. As per the there was a trial known as post-trial trial. We follow that particular pattern. Usually give a long duration. We proning for a longer duration at a single stretch, that is approximately around 16 hours. After that, we will make him supine, and depending on the response, we will again prone him. Okay. And we can continue these proning sessions for any number of times. There is no limitation. And what happens if a cardiac, usually one of the concerns of proning, the staff concerns, staff is concerned, okay, staff who are not experienced in proning or who are not working in prone centers which regularly do proning. So they are concerned what happens if the cardiac arrest happens when the patient is on prone. That is one of the factors which prevent some clinicians, or at least some, not intensivists maybe, but some clinicians from doing a prone ventilation. So if cardiac arrest happens, you can commence CPR in the prone position itself. You can place your hands, you can give compressions at the mid-thoracic level between the scapula. Okay, and you can even defibrillate in that position. And if he is not responding, or if his ROSC is not attaining, you can make him supine. And strategies in ARDS. Am I audible?
Yes, sir.
Yeah, you are audible, sir.
Okay. So regarding the fluid management strategies, that is okay, fine, thank you. Conservative strategy, that is, there are two types of strategies. Keeping on giving more and more. Okay, any event you give fluid boluses. And conservative means we are keeping the fluid bolus fluid intake on the lower side, just what is required. So for ARDS, conservative fluid side is ideal because it has been found to improve the lung function, shorten the duration of mechanical ventilation, duration of ICU stay, and okay. So we go for a conservative fluid management. Try to avoid overzealous fluid administration. Okay, so now our patient had a proning for around 4 sessions, that is 4 into 16. After making him supine after the 4th session, still not improving, or it is still less than 100. Now, what is the next option? I told you there is no limit for proning. We can even go for another session of proning. There is no issue with that. But we have one more option left. If the patient is, if your center has that facility and your patient is affording, is able to afford, option. Okay. In such situations, that is, even he is not responding to lung protective ventilation, he is not responding to other adjunct methods, he is not responding to proning. We have our extracorporeal techniques, ECMO, mainly ECMO. ECMO is also there for carbon dioxide removal, but mainly we more commonly use ECMO. Okay. So if your center has an ECMO facility and if your patient can afford, or even if your center doesn't have an ECMO facility, you can refer in at such a point of time, you can refer him to a center where there is ECMO facility, so that they can initiate on ECMO when needed. Okay. And but so ECMO, you know, it is nothing but we are doing. ECMO machine is doing the function of lung. You're drawing the blood out of the and you are returning it back to the patient. Okay, so basically, ECMO machine is doing the function of lung, and during that period, we are allowing the lung to heal. So this is how we proceed with ECMO. That is, patient still PF ratio is still less than 80 with an FA2 requirement of more than 0.9. And other methods, including proning, have failed, or CO2 retention is there, or we cannot achieve a safe plateau pressure. That is, plateau pressure less than 30 cannot maintain without, that is, lung protective ventilation cannot be maintained. In such a situations, we can opt for ECMO. But if you're opting for ECMO, it is ideal to initiate ECMO within 7 days of mechanical ventilation, because if you are initiating ECMO after a 7 days period of mechanical ventilation, the chances of recovery are comparatively less. The patient 4 session of proning, that is, day 1 we intubated, and another 4. Okay. So day 1 we intubated, 24 hours we intubated, and another 4 days we proned. So that is today's day 5, and now we are going for ECMO. So if you're going for ECMO, better go within 7 days of mechanical ventilation. And if the patient is not affordable, if patient is not able to afford ECMO, and if there is no option of ECMO in your center or nearby center, then you can, if this is the scenario, you can go for further sessions of proning. So basically, summarizing, basically the lower tidal volume, that is ideal body weight, 6 ml per kg of ideal body weight, and prone positioning. These are the 2 techniques which have which are found to affect the mortality, which have mortality benefit. That is, if you do follow these 2 techniques, there are high chances of survival. So these are the 2 techniques which you should definitely use for an ARDS patient. Okay, I think that is the end. Bharath sir, you have anything to add? before we go to the questions?
I think everything is very comprehensively covered, sir. I think what a critical care nurse needs to be know on a daily, day-to-day basis, everything has been dealt with. So at this point, I would like if some of the participants can come up with few doubts or questions. We can spend some time interacting with them. In the chat box, I don't see any new questions.
Yes.
Are the participants are allowed to speak?
Any doubts you can.
Deepa ma'am?
Yes, sir. Sir, if they raise their hand, now then I allow
I
them to
can't
speak.
hear you.
Sir, if they raise their hand, because no participant had raised their hand yet, if they raise their hand, then I'll allow them to talk.
Okay.
So ask question in chat box. With the chat box, you can communicate with participant because this is a webinar.
Yeah. So participants can't speak.
Yeah. Yeah.
If
Durga has raised.
participant raise their hand, then I allow them
Yeah.
to speak.
Yeah.
But
Yeah. Somebody.
yet,
No. Somebody has raised their hand. Durga has raised their hand.
Hello, can you hear me?
Yeah, you were mute earlier.
Yeah, okay, yes. Okay. Okay. To start with, Dr.
raise her hand,
Kiran
but
sir
she could not
had
speak anything.
started a case scenario where the patient is hypoxic, and at this juncture we had discussed few modalities how to address this issue. Then we had proceeded to definition of ARDS, and basing on that we had come to a conclusion what is the severity of this patient. Following that, we had given options whether we need to intubate or we need to put an NIV. Initially, we had discussed about option of non-invasive ventilation in ARDS, giving a NIV trail, failing which we had proceeded to invasive mechanical ventilation. If at all a patient with severe ARDS needs to be intubated, what is the ventilatory protocol we need to follow that Dr. Kiran Rajagopal had discussed in length? I think that is very much sufficient. After intubation, we had ventilated the patient in a lung protective ventilation strategy. It's a strategy to balance between oxygenation and not to, at the same time, not to injure the lung. So we will watch for some time whether the oxygenation is getting improved or not. Failing which, next we proceed to another evidence-based strategy, which is prone ventilation. After prone ventilation, we had discussed what is the nursing aspects which we need to take care for a patient who is prone on a controlled mechanical ventilation, because just pushing the air into the lungs, increasing the oxygen levels is not going to be the complete treatment. When there is a good nursing care, especially to prevent this bed sores, because these patients will be lying in a fixed position for hours together. it doesn't make it doesn't make a comprehensive critical care approach. So after prone ventilation, we had seen whether he can he shows any improvement in terms of improved oxygenation. So even with these evidence-based strategies, if the patient has not improved, then at the last resort, we are left with extracorporeal membrane oxygenation. So that the ECMO also has been dealt with some with few details for a basic nursing students or basic nursing people. And throughout this webinar, we had started with a patient who is requiring some increased oxygen requirement, which can be provided with routine oxygen delivery devices, and it had stretched up to a costliest treatment like ECMO. So as a nurse, what you are supposed to do is, throughout all this process, you should be aware of the disease condition, you should be aware of the severity of the disease, and also you should be a part of the team. You should be a part of the entire critical care team, because all the team members will be having a definitive, defined role to play, because one person can't handle the complete responsibility 24/7. It is the nurse who is going to stay with the patient, such a critical care patient, for most of the time. So these nurses should be aware what is the ventilatory setting, how is the ABG, what is the initial ABG, after with this ventilatory strategy, how the ABG had improved, on what basis the critical care physician is changing the ventilatory settings. Most importantly, what is the initial FiO2, what is the initial positive end expiratory pressure, PEEP. Day by day, how these two parameters are changing, whether they are increasing or decreasing. So when the requirement is consistently higher, we had discussed other strategies like prone ventilation, because nursing a patient in supine position is a little bit familiar, and nursing a patient in prone position is not which we do regularly. So nurses should be familiar with this type of nursing issues, because prone ventilation is the one which we do almost exclusively for this ARDS condition. For other conditions, other than changing the patient secondarily from left lateral to right lateral, we don't regularly prone them. So this is a condition which demands prone position for hours together, or if required, even days together. So the time when you change from prone to supine or supine to prone, it is the time where we need to take care of all the gadgets devices, like the endotracheal tube, central venous catheter, arterial lines, ECG leads, Foley's catheter, all those things. And second thing, we need to take care of the pressure points. Are we sufficiently padding the pressure points? What precautions are we taking? Even the physician overlooks these things. It is the responsibility of the nurse to take care of all these issues. So in this way, nurse plays a very crucial role in managing such critical cases, which helps in improving the outcomes, especially a prone ventilated patient with ARDS. So in the chat box, I don't see any questions, ma'am.
Yes, sir. So the time is also over.
Yeah.
So we can
Okay,
wind up Dr. Kiran Rajagopal, wind up the session.
Yeah. Okay. Fine. Shall we go to the MCQ session?
Yeah, yes, sir. Yeah, sure.
Okay, fine. Okay, we will have some 6 MCQs, some 6 questions, and I think you should give the answers, right? Okay, first question, that is which you have a patient with a respiratory failure, and you have done an ABG, you have done an X-ray, you have done an CVP monitor, you have SpO2 monitor, and among these monitoring techniques, which one will give the most specific information regarding the efficacy of the intervention we did for a patient with ventilator failure? Let us say a patient is having a respiratory failure, and you did something, you kept him on an IV, or you intubated, or you did some you prone, or you did some intervention. And to assess the adequacy or assess the efficacy of that intervention, which among the following is most useful? Is it an X-ray, or is it a SpO2 monitor, or is it an ABG, or is it a CVP monitor? I have got some responses. Yes, to have got the right answers, it is an ABG, because you know whether your oxygenation has improved, whether the carbon dioxide levels have come down. And so X-ray, the changes will take some time to be visible in the X-ray. And if you go by the oxygen saturation alone, you will not get an idea about the carbon dioxide levels. Okay, your oxygen saturation might be normal, but your carbon dioxide will be very high. Okay, CVP has no role in a respiratory or respiratory failure management as such. So the answer is ABG. Okay, so ABG is the most useful tool in any case of respiratory failure. Second question, which of the following statement is true regarding ARDS? Okay, A, this condition develops because the exocrine glands start to work incorrectly, leading to mucus secretions in the alveolar sac. Or another B, ARDS is a pulmonary disease that gradually causes constriction of the chronic obstruction of the airflow from the lungs. C, ARDS occurs due to collapsing of a lung because air has accumulated in the pleural space. D, this condition develops because alveolar capillary membrane has in the alveoli sacs. So which of this describes ARDS best? A, B, C, or D? Yes, answer is D. Because remember, ARDS inflammatory mediators are there. It leads to damage of the alveolar capillary membrane, which leads to increased capillary membrane permeability, leading to interstitial edema and fluid filling of the alveolar sacs. Answer is D. Third one, all are true regarding lung protective strategies in ARDS ventilation, except tidal volume 6 ml per kg actual body weight, plateau pressure less than 30, SpO2 around 88 or 95%, VCV or PCV mode. Which of the following doesn't fit in the lung protective strategy? That's the question. Yeah, yes, it is A. Okay, it is not D. D actually, volume control or pressure control, either one is okay. But see this, see the option A. It is tidal volume 6 ml per kg of actual body weight. It is not actual body weight. It is ideal body weight, because it is said that the size of the lung is related to height rather than weight. So ideal body weight we usually get from the height, right? So height of the lung is more, size of the lung is more related to height than body weight. That is why we use 6 ml per kg ideal body weight. Okay. So diagnostic criteria for ARDS include all except. I hope you didn't see the answer. Bilateral infiltrates on chest X-ray, no evidence of cardiogenic pulmonary edema, PF ratio less than 200, and the onset within 1 day of insult. There is diagnostic of all except. C.
Someone
Yes,
had
answer
answered
is-
C.
Yeah. Yes, because basically for diagnostic purpose, PF ratio should be less than 300. PF ratio less than 200 is definitely ARDS, but ARDS starts even above 200, that is less than 300. Okay. So another one, prone position is being used for a patient with a severe respiratory distress syndrome, and which information indicates that the positioning is effective. So you have proned the patient, and how do you know that your proning session is effective? Post-proning, the patient's PF ratio is 200. The patient was a severe ARDS patient. Post-proning PF ratio is 200. And post-proning, the endotracheal suctioning, when you suction the patient, the sputum is clear, whitish and clear. I mean, clear and thin. And sputum and blood cultures you sent after proning showed no growth after 48 hours. And the skin on the patient's back is intact and without redness. Which among the following indicates that your proning has worked? Yes, answer is A. See, it was a severe ARDS patient. That means the PF ratio was less than 100, and post proning, his PF ratio has improved to 200. That means your proning is doing some effect. All other things that has nothing to do with proning. And the last question, which of the following is not generally beneficial in an early ARDS? Liberal fluids, neuromuscular blockers, physiotherapy, mechanical ventilation. Which of the following is not beneficial in an early case of ARDS? Is it liberal fluids, or is it neuromuscular blockers, or is it mechanical ventilation? Which is not beneficial in an early ARDS? No, it is not neuromuscular blockers. I told you, you can give for 48 hours, even though there is no mortality benefit in the initial 48 hours. Early period, you can give to prevent patient ventilator asynchrony. See the option A. Nobody has given the option A. Liberal fluids. I told you, in ARDS, we go for a conservative fluid strategy, not a liberal fluid strategy. Yes, it is liberal fluids is the answer. We go with a conservative, restricted fluid strategy. We do not give fluids overzealously. Okay, so liberal fluids are associated with harm, definitely. I think that was the last question. So,
I think audience had reasonable participation, at least for the MCQ session.
Yeah.
Okay, this will help as a primer, and once they go back and read, and whatever
Yes.
they had doubts, they can come back. We are available anytime.
Yes.
So I thank all the participants, and I thank Dr. Kiran sir for your valuable time and for your enlightening lecture. And I think we can conclude the session for today.
Okay. Thank you all. Thank you, Dr. Bharath. Thank you.
Thank you, sir.
Thank you, Deepa. Thank you. Thank you all. Thank you.
Thank you, sir. Thank you, sir. With your permission, I'll just end the session.
इसका स्टार्टिंग से